Hi, I'm Dr. Zhaojing Wang. I'm a dermatologist from Taiwan. Being the Conference Secretary General of AMWC Asia TDAC 2022, I'm here to welcome you to join us in this special edition of Pre-Congress Advanced Injectable Workshop. Tonight, we're really happy to have three well-renowned speakers to share their latest technique of injection with us. Let's welcome the first speaker, Dr. Uliana Good. Uliana is the founder of London Aesthetic Medicine Clinic and Academy. She is the president of the British College of Aesthetic Medicine and scientific director of Face Congress London. She is a passionate global educator and trainer within the field of aesthetic medicine. Tonight, she will talk about her tips in the quick fix for sad mouth angles. Let's welcome Uliana.
Well, hello, my fabulous friends from around the world. It's such a pleasure and honor to join you today, albeit virtually. So let's start and talk about sad mouth corners. We all deserve a great smile. So my take on this situation. Now, for those of you who don't know me, my name is Dr. Uliana Good, and I work in London, Harley Street. So please come and see me after this COVID pandemic settles down. I'd love to keep in touch. Now, my Instagram handle is @UlianaGood. Please do join me. I'd love to build my community of friends. So here we go. These are some of my credentials, just so you know who I am and what I do. So I'm the founder of London Aesthetic Medicine Clinic in London, Harley Street. I'm currently the president of the British College of Aesthetic Medicine in the UK, scientific director of Face Conference in the UK. Please do come and join us next year. A pleasure to be course director for Monaco AMWC and sit on the board of the International Peeling Society. Now, many of you have seen these books. It's been a pleasure to collaborate with my friends around the world. And one of them actually, in fact, two, look at lips. And I'll tell you my personal tips that we actually talked about in these books. So guys, I have 12 minutes and I want to share with you four things. One is why it's important to talk about lip corners, the Zoom face phenomenon that's going around the world because of COVID, and why it's important to look positive, and why we have a demand in lip corner treatments. Number two, I want to tell you my personal technique called focal needle approach, how I flick it in 1 second. Tip number two is my cannula lip approach, marionette approach, and chin. Why it's important to not just treat the corner focally, but wider throughout the lower third of the face. And finally, I want to share with you my personal recommendations for treating skin and treating the platysma with toxin when we talk about lip corners. So let's go. Zoom face and positivity. So guys, you know what I'm talking about. I have patients come to see me now and say, I look a little bit sad, lift my corners up, give me a better look, make me look much more healthier. So I've just shown you some pictures of a younger patient and her mother who's more mature. Lip corners really make an impact on how people perceive us. Now look, in the UK, and I'm sure internationally also, you've had a lot of press coverage. This is from The Sun, a newspaper that is very, very famous in the UK. And people are disappointed with the way they look on Zoom. They feel they look tired and they look sad. And why are lips important? Well, guys, we know this. When Jarbus in 1967 published his central facial triangle, he said, the lower face is one of the most important areas in terms of how people see us, because that is our central communication point. So lips, and especially lip corners, are very, very important to treat and know how to treat. Now, is it all about fillers? That's the question. Is it just putting fillers in the skin or the subdermal plane? Well, in my opinion, it's much more complicated than that. We have to support the bony structures underneath, which resorb with time. We have to support the fat pads. We have to support our teeth in some cases. And of course, we have to relax the muscles and treat the skin. Now, guys, you know this. I don't need to tell you, Mendelssohn and Wong did a fantastic study in 2012. And look what happens. We lose volume in the marionettes, pre-jowl sulcus, and the chin crease. Now, of course, when you lose volume and the bone resorbs, the corners will naturally slide down. So we must support bone loss, particularly when people hit their 40s. Now, when it comes to fat pads, we know we have superficial, we have deep fat pads. Well, we know we have resorption of the deep fat pads, rotation as well, and we have movement of fat pads at the same time. So this area often becomes volume deplete through here because of the bone loss especially, and we have accumulation of fat laterally in our superficial fat pads. So we have to find ways of smoothing this area because it will affect the corners of the mouth. Now, when it comes to muscles, muscles have a huge impact on the corners. Now, look at this. One of the most important muscles is the neck muscle, the platysma. Now, if you do this, E, you can see the platysma pulls down the corners of the mouth. Now, the other muscle that I always need to treat is, of course, the DAO, depressor anguli oris, and, of course, the perioral muscle, which is the orbicularis oris too. Now, skin for me, as you know, I love skin treatments, and this is a book we published in 2014. Skin is everything. You know, if the skin is photo damaged, if there's a lot of problems with aging on the skin, the corners will be turned down. Of course they will. So we have to also support the skin. So let's talk about tip number 1, the focal needle approach. In 1 second, you can get a fantastic turning of the corners. This is how I do it. So please, no photography, no videos on this. I'd appreciate it because the patient didn't want that to be done. So here we are, guys. Look, can you see the thread of filler I put on the skin? That's what it will look like in the dermis. I've just shown you the thread. So I take my needle. This is you can take a 30 gauge, a 27 gauge, medium viscosity HA filler intradermally. I aspirate at this point, and I deliver a thread of 0.05 mil. Very slowly, you can see I go from the vermilion border up into the white lip and retrograde. Now look at this, 0.05 mil. And look at the difference. Can you see how much lifting you get with so little product and within 1 second of treatment? Now, this is a great place to start. However, often in patients who are more mature, who have a lot more muscle pull, who have more skin problems, you will find this doesn't give you the full result. So this is how I supplement it. I supplement it with a cannula technique. You can use needles too, it's up to you. I prefer cannulas, and I supplement the lip, especially the lower lateral part of the lip, the marionettes, and the chin crease. Let's take a look. So I have a cannula here. Now I like to use 23 gauge cannulas. Sometimes I use 25, but mostly 23. This is a nice soft filler designed for lip volumization and hydration. This lady clearly needs a lot of lip hydration. She's very beautiful, but lips could be hydrated, and we can flick the corner with this technique. Now look, the cannula is rotated. You see how I turn it like this? And it goes into the first tubercle. The lower lip has 2 tubercles either side, and it has a dip in the middle. And I do a retrograde thread. I put a bit more in the tubercle, like 0.05 or 0.1 in the tubercle in the middle here. And as I pull out, you see here, I withdraw and I deliver product here. And you can see that lifting right there. It is such a quick technique to do. It takes again another second. And here I've delivered 0.15 mils of product, HA filler. So this has now supported the lower part of the lip, the body of the lip, particularly the lateral angle next to the modiolus. That will also help to lift the corner. Now, the final bit I want to do is I want to support, let me just play this video. I want to support the marionettes and my chin crease. Now look, I take a needle. I'm going to use a 23 gauge cannula. You can use a 3 centimeter, 5 centimeter, depending on the length. And here I am going to support this area, which is collapsing when I press it in. And you can see the mentalis in this lady is riding up. She's got a strong mentalis there, creating the chin crease. All of that is creating shadows and weakness. We want to support that because it's part of the corner of the mouth treatment. Now you see here what I'm doing is I'm putting a little needle injection, rotating it just subdermally, nothing exciting here. And we pull out. And now we're going to insert our cannula. Now look at this. So here's the hole. I made it nice and easy for myself. I take my cannula, I like to use a 23 gauge cannula. Some people like to use 25. I just prefer 23. And I'm going to be under the skin. So here it is. Bevel is facing upwards. I prefer to do that. Here we are. I'm using a medium viscosity HA filler. I want a lifting capacity. I don't want it to be too soft, and I don't want it to be too thick, because that creates some lumps and bumps. So I stretch the skin and I insert my cannula and I guide the cannula just under the skin. Don't push too deep, just under, and you're kind of like rotating and scraping the underside of the dermis. You see my non-dominant hand is stretching the skin, and I'm guiding the tip of the cannula to the top of the mouth, the corner of the mouth. Right at the top, you'll see in a minute, there's no need to aspirate because this is a cannula. I'm at the corner, at the modiolus, and here I'm going to start to press. And I'm going to push the filler, and you'll see it's starting to lift the corner up, and we're going to get a wonderful lifting result. Look at this. Can you see the plumping in 1 second? Here we go. I'm just positioning myself. And here we are delivering the product. Can you see the tissues expanding very naturally, very gently? And you see when I compress, the weakness that would have been the marionette is getting supported. So that's good. So then I rotate the cannula a little bit more medially because I want to treat the chin crease. So here we go. I stretch the skin, twist, twist, twist. That's my action with the cannula, very gently. Don't push too hard, too fast. It's a bit uncomfortable. I go to the middle of the chin crease subdermally. Here we are again. And look at this. You'll see the volume plump up instantly. Very natural result. Can you see how beautiful that is? Cannulas give you that beauty. You're creating a plane of filler injections. For me, that is important. It looks so natural and elegant. And here I'm putting a bit more product in the pre-gel sulcus. Here we go again. Going to put a bit more product. And effectively what I'm doing is a fanning technique. You see, I fan it like this from the corner of the marionette down into the chin. And sometimes I can even put it in the middle of the chin here to push the chin more anteriorly as well. So lots of techniques, but please be gentle with cannulas. Don't be too forward and back. Don't push it. Twist the cannula. It will find its own space underneath the dermis. Now look at this. You'll see it in a moment. Look at this. The shadow will disappear in a moment. It's beautiful. It's so quick. It's efficacious. It's safe. I love these treatments. So here we are. You keep on doing this. It takes often about 5 minutes to give a nice layer of filler in that marionette, pre-jowl sulcus, chin crease, and sometimes even to the chin. You're trying to smooth the whole layer so everything looks nice and elegant. Very, very easy to do. Don't rush it. Take your time. So that is it. You see, we're finished. Look at that. Much more structured. Everyone deserves structure in this area. Okay. This is an example of the treatment. She's smiling on the picture after, I know, but you can see the light reflex, more hydration. The corners are much more stronger. You can see the shadows. Look at this. The shadow in her chin crease is much more improved. The chin I have thinned out. I've made it more V-shaped, so she looks much more youthful and happier. And also I've supported some of the early collapse and shadows on the marionettes. You see through here and through there. Now I have another patient. This is a more mature patient. You can see the improvement you can achieve in the shadows. This is the corner turning down into the marionette and the pre-jowl sulcus. Look at this, much more smoother, you see. Look at the corner here, again, more supported. The structure of the skin and the tissues is much more stronger. And look at this again, that shadow, that weakness in the tissues is now supported. And the lips, of course, look even better. So when you do lip volume, always fix the corners. Again, another patient. And here I'm just going to show you something interesting. I haven't done too much to the corners because the corners in her were quite good. However, you see the dryness, the vermilion border being completely disrupted, the volume being disrupted because of skin damage. And these shadows here, I've used literally 0.6 ml of a syringe here, nothing dramatic, but sometimes the corners are not everything. You have to support the vermilion border, the hydration, the marionettes, the chin crease too. So, you know, when it comes to mouth, you have to treat everything together in one go, ideally. Finally, tip number 3, skin and platysma. Now, this is a book we published in 2014. These are the beautiful results you can lift with corners of the mouth with chemical peeling or lasers. I love this. This is a deep dermal peel. So if you're interested, please join the International Peeling Society, www.peelingsociety.org. We will show you how to do these treatments. Beautiful corners of the mouth lifted and tightening. You get a tightening here. Again, pigmentation treatment can make a difference to the perception of the lip corners. The lip hasn't been changed here. We've just removed the pigmentation. And of course, for me, skincare is everything, you know. You've got to have good skin, and lips deserve, and the perioral area deserves great skin. So this is my morning and my evening protocol. I use a lot of exfoliants, retinoids, depigmenters, and of course, great moisturizers. So guys, final point of the day for me is muscles. And I'm going to show you 2 muscles that I treat, DAO. And the DAO is this muscle through here, you see here. When you turn the corners down, you see these little lines through there. Half a unit I use lateral outer aspect here, and half a unit here intradermal. Okay, don't go too medial because you will get problems. And the other muscle I love to treat is the platysma. Now look at this, platysma in this lovely lady. She's a celebrity in the UK called Ulrika Johnson. You can see when she's gurning, the corners of the mouth are going down and the platysma bunches up. So this is how I treat it. You see this lovely lady here. There it is. You see the platysma even comes into the corner of the mouth. The platysma does insert into the lower face. And here is toxin. I'm using sometimes 50 units of botulinum toxin. And I go high dose at the top here, something like 5 units, 5 units, 5 units. And then I bring it down 2 units, 2, total 50 units of botulinum toxin, or you convert it to your other toxins if you wish. These injections are done intradermal or intramuscular. Ideally, the central portion, be careful here, because if you put too much of a dosage here, you can affect the swallowing mechanism. So please, central injections, be careful. Intradermal, half unit dosages. I put maybe 5 units in total. I'm just cautious. I don't like complications. That's it. I'm done. I'm going to summarize by saying COVID has made a new focus, a new phenomenon called Zoom face. And Zoom face has made us focus on the lips, because this is the area we communicate with and we look at most when we look at people. We are all wanting to look more positive, more happier and healthier. This is why lip corners matter. For me, fillers are the #1 treatment. I know. I use a needle, I use a cannula. However, if we just do fillers, it's often not enough. We have to treat the muscle effect of the platysma, the DAO especially, sometimes the orbicularis oris, and improve the skin. So with that in mind, I'm going to say thank you so much for having me today. I hope you have a lovely session. Do please link in with me on Instagram at Uliana Gut, and hopefully we will all see each other face to face very soon. Take care, my friends. See you soon. Bye-bye.
Wow, thank you, Uliana, for the brilliant talk. And I believe that we all know how to help our patients to have great smiles now. And the next speech, I can guarantee you, is groundbreaking. Our next speaker, Dr. Johan van der Putte, is a plastic surgeon, now based in Belgium. He founded the Division of Plastic Surgery Unit in the Oudenaarde General Hospital in 1995. And his private practice is devoted to minimally invasive cosmetic procedures. He has held presentations and workshops at plastic surgery and aesthetic medicine meetings around the world. Today, he will talk about what is really going on with hyaluronic acid gels in the subcutaneous. Let's welcome Dr. Johan van der Putte.
I need to disclose that I'm going to mention 2 brand names for accuracy. They are competing. This is the research done by a team of clinicians, histopathologists, radiologists. It's entirely our initiative, but it was sponsored by a restricted grant from Merz Aesthetics. It was peer-reviewed and published in the Aesthetic Surgery Journal. I thought I had a few questions to answer. we read a lot about intradermal injection of fillers, but most dermal fillers go below the skin. How do they really spread in fat tissue? Is ultrasound reliable to detect uncomplicated HA if there is no capsule? When we pinch injected zones and massage them, does remodeling really help to spread? Do cannulas really get the product where we intend them to be? What's the tissue response? And do we observe some filler migration? So what I did was ask patients who were scheduled for breast reduction or abdominoplasty if they would participate in the study. And I injected 2 brands of HA gel designed for deep injection in the subcutis of the area that was going to be removed during the surgery. And right after injection, I gave a good pinch to the lateral parts so that we would have a remodeled and a non-remodeled part. And everything was monitored by ultrasound injection. We also measured the size of the deposits, and then we repeated the measurements after 10 days to 3 months and repeated the experiments across the midline so as to get 2 histopathology specimens on surgery, 1 short term, 1 intermediate term. Histologically, they were examined by 3 transverse sections, and the largest measurements out of 3 were noted. In fact, were measured the filler pools and then the total spread of the fillers, and of course the tissue response was examined. Now, how was the spread? This is a film of accurate linear retrograde injection of Juvederm voluma, and we see a serpiginous trajectory, and under ultrasound we can really follow how the gel is injected into the tissues. If we do the same with Bellotero volume, in fact, the injection looks slightly different. It comes out it looks like separate blobs and spindles, perhaps because the product is a little more cohesive. But when the radiologist is moving the ultrasound probe, we can see that basically it's a very similar serpiginous trajectory. The ultrasound characteristics of the gel are slightly different. Bellotero volume is hypoechogenic, and there is a sharp delineation. Juvederm voluma has areas of hyperreflectivity, isoreflectivity, hyporeflectivity, and it's it's less well delineated, sorry. Does this make a difference when we look at it under the microscope? No, totally not. There was no way that the histopathologists could make the distinction between one product or the other. And I think that's one important message. This is the total spread of filler, and that is what I mean with filler pools. Now, these pools are large. They usually are as large as the total spread. So the fillers don't go in between the individual fat cells. They are sitting there like large deposits. I think this is an important message. It's totally different from the intradermal spreads where the filler go in between the lattice formed by the collagen network. Now, can we really detect everything with ultrasound? Following the injection, real time, no problem. But then if we plot the maximum dimensions of ultrasound versus histology, we see that they have the same order of magnitude when we're speaking about the dimension parallel to skin. But then there is something weird. When we speak about the dimension perpendicular to skin, we see that the histological measurements, mainly of one product, are larger than the ultrasound measurements. So I suggest ultrasound does not always pick up the entire size of the deposit, and it depends on the kind of product. It depends on the ultrasound characteristics. Now, these examinations were performed by a professional radiologist with a 12 megahertz probe. We should bear in mind that nowadays, 4 years later, we have 40 and even 50 megahertz probes, so I really wonder if the results would be the same. Just a little reminder that I pinched half of the deposits to see if it made any difference. And in fact, if we have a look with ultrasound, that's before pinching, and that's the part that was remodeled. Immediately after remodeling, we can't see it anymore. Same thing over time. Over time, sometimes it's barely detectable, but the histology proves that the product is really still there. Does remodeling help to spread the product? How about histology sizes before and of the remodeled and the non-remodeled bits? In fact, they have the same order of magnitude. It seems that when we remodel, we cannot really push HA through the tissues. So when we are remodeling, are we really spreading filler? I think not. I think we're merely changing the shape of these individual little deposits. And I don't believe, but I cannot prove it, I don't believe that we can move product with our fingers through septa. Another thing, we monitor it real time. Do cannulas really get the product where we intend it to be? I thought I was performing a nice linear retrograde injection, and there you see a tip of a cannula pushing on a septum, and all the product flows backwards. I was thinking I was doing a good job with the linear retrograde injection, and there is a big fat bolus and a trajectory which is much shorter than I expected. So I suggest when we feel resistance from a septum, let's not inject and hope to remodel the product a little further on, because this is what we may get. How is the tissue response? And is there any filler migration? Now, there was a semi-quantitative assessment, and in fact, we know that generally HAs are very, very well tolerated by the tissues. There is no necrosis, no acute inflammation, scar formation is rare, and there is only a little bit of chronic inflammation. We asked the histopathologists after unblinding, it was double-blind histopathologist patients, can you detect any difference between the brands? Can you give us any guess if the product is spreading over time? Because we had short-term and mid-term, and no, they can't detect any migration, and they can't detect any difference between remodeled and unremodeled. It looks the same. CD68 staining is a special stain for histiocytary reaction, and it shows a little bit of a macrophage and histiocyte response. We know that most of the HA is breaking up into lumps, transported in the lymph, and digested at a certain distance in the lymph nodes, in the liver, and in the kidneys. There is little local response. One of the products gave rise to a granuloma, and the amazing thing is it was only in the remodeled part. I think a lot may be going on under the skin that goes unnoticed. There were no clinical signs of that granuloma. So, this is a research article. I could only give highlights. It's published, and I really hope you read the article. And of course, for the future, we need higher numbers of patients comparing histology and ultrasound. And I'm really very curious how this modern ultrasound, 40, 50, 60 megahertz, is at detecting filler deposits deep down, because there is a problem with the classic radiology, with the classic ultrasound that radiologists are using. We can't see everything. Thank you very much for your kind attention.
Thank you, Johan, for the groundbreaking talk. And for the last speech, I would say is absolutely fantastic. Our last speaker, Dr. Anil Rajani, will share his insight in the application of the platelet-rich fibrin gel in aesthetic field with us. Dr. Rajani is a world-famous aesthetic physician. He has over 20 years experiences with lasers, neuromodulators, threads, and fillers. Plasmascope, plasma lip, and plasma eyes are his signature procedures. And he's a trainer and lecturer for various international aesthetic companies. Let's welcome Dr. Anil Rajani.
I'm Dr. Rajani, and I want to thank you for joining me today for my lecture on the advancements in platelet-rich fibrin. Today I'm talking about platelet-rich fibrin and actually heating a portion of the blood to form a gel matrix, adding the PRF back with its growth factors, mesenchymal stem cells, and injecting it similarly to how we would a filler. It injects through a microcannula with a 1 ml syringe. I'm going to go through a little PowerPoint here. We're going to watch it being made with a video and some video injections, and I'll walk you through those. I have a practice and have for over 20 years now, provide many different types of injectable services, trained for many of the different companies, including I use PDO threads and platelet-rich fibrin, and my journey started with platelet-rich, I'd say plasma first, of course, because many of us did, around 2010 when the first microneedling devices came out and we were taking PRP, the first generation blood product, spinning it down, and that was one of the first applications, and then some under-eye injections. Well, 2015 rolled around, I heard about platelet-rich fibrin and started using it. I struggled. It would clot right away. So I started adding some heparin to it. And then I reached out to some of the thought leaders and people in different countries who do platelet-rich fibrin. They said, Rajani, it's all wrong. You don't add blood thinner, it will ruin it. So at that point, I went down the rabbit hole of wound healing, studying a little bit about fat grafting, mesenchymal stem cells, healing factors, and then that takes us to today, where in 2015 I threw away the PRP and only use the PRF because my patients' results with the PRF were amazing. I figured out how to do it and inject it as a liquid back into the faces properly. And today now we can heat the gel, make a matrix, and gel it in the same way we would inject a filler through the microcannulas. I'm going to take you through that. But I trained for many of the companies, and that's kind of my history and journey with blood products in relating to today's talk. So a lot of what I'm going to talk about today, some of the information, especially for our patients, is on YouTube. I don't go into a lot of the technical details, but just an overview so people know kind of what it is and what it does. I have an aesthetic training center at aesthetictrainingcenter.com. And there is a free course if someone wants to do it and learn more about this easy gel technique. And it goes into a lot of the details I'm going to show you today, but slower, and into a little more of the science. So if you look up here, this is a little rundown of what it is. If you look up here, we have our syringes, different ones that are heat resistant. I'll take you through that in the video because, of course, you're going to be heating to 70, 75 degrees with these syringes. So the plastic is made as such for that. Here you have a spinner for a slow spin speed. You have a heater and a cooler. If you keep in mind here, a spinner is married to the tube, meaning a spinner should be studied for the angle, the spin speed that the tube correlates to, because it's very complex, but essentially we want to measure the G-force of the spinner at the Buffy coat. This is all about the Buffy coat because that's where the white blood cells, the platelets, the growth factors are. Different angles, different speeds, different tubes will change everything. And that is a rabbit hole for those interested. It's very fun to study, but it can be complex. Here is where I'm mixing the albumin, the heated albumin, and the liquid PRF. Again, I'll take you through that. And over here, you can see the 3 syringes. Now, you get a total of 5 with 2 13 ml tubes of blood, which is what comes with this kit. So you're going to get 5 1 ml syringes to inject. But that gives you an idea what they look like. And this is what the gel looks like. So if you look up here, you can see that it's fairly robust. I mean, it has a fairly high G prime. This is an advanced thing, but you can play with how much G prime you want because you add more liquid PRF to it, the less G prime and more gel like it would be. Conversely, the more you heat it, the stronger and robust it will be, but you have to treat the proteins well. They unfold at around 70 to 75. More on this later, but understand, just wanted you to see what that gel might look like. So in terms of data and studies, just like everything else, we're very early in aesthetics, just like we were with PRP and now PRF, in terms of a double-blind, placebo, randomized, controlled, prospective trial, just like we are with fillers, biostimulators, and everything else. But you'll find ones like this, the assessment of the efficacy and safety of platelet-poor plasma gel, so just the gel component, used as an autologous filler for facial rejuvenation. And I don't think of these in parallel with filler. They're much more. It's one's own body's growth factors, mesenchymal stem cells. However, this study, they had 2 groups divided into A and B, one for wrinkles, one for tear troughs. And you can go through and read the results, but they looked at the wrinkle severity rating scale and the tear trough rating scale, and there was a 1 to 2 point improvement at 3 months with just the gel. Similarly, in journals like Platelets, you'll find studies like this in which they're looking at the growth factors. So you can see here, I'll talk to you a little bit about the growth factors, but they were looking at the growth factors at 10 days and how they hang in there in the body to help rejuvenate and get those regenerative properties. So for those who are interested in the science, there's a lot of peripheral science, but the gel fillers were definitely early, or I should say in the gel platelet-rich fibrin components. So if we look here, I wanted to share with you what I've done over the past couple of years, really over the past year and a half that I've been playing with this. If we look here, this is a patient that came in. If you look at her smile line on the left, and you look here on the picture on the right, you just see a yellow hue. The yellow is the 3D camera measuring volume, and you can see an increase in volume, and these were taken at about 2 months afterwards. And so what I was doing was measuring the results slowly in different areas on the face, and I did a lot of people, their nasolabial folds. And so I know originally in all the studies, very early, take the collagen and of course the Restylane, which was approved in 2003. Everything's based on those collagen studies of the nasolabial folds. So I was just injecting a lot of nasolabial folds to play with it. So I have pictures like this in 3D imaging where I follow them to show that we are increasing actual volume over time. But this gives you an example of that. So I'm going to get rid of these markings and let's move on to the next slide. If we look at this one, here's a before. Here's an after. Now this is an immediate after filling, and you can see the yellow up and through these areas where we filled. And just to show that what I use the 3D camera for is measuring over time to see what exactly we're getting. I'll remove these markings, but in this person, we were just injecting the cheeks and the smile lines to see the effect that we would get and the volume effect over time, but we can now measure these things with 3D imaging, so it's actually really cool. This shows you a picture she sent me 2 days later, just saying this was the first cheek filler she had, how much she liked her cheeks, but you can see very minimal downtime with these type of procedures. This shows on the 3D camera, so if we look over here on this side, if you can see the fine lines, these are vectors, they're little arrows, and they show what we're doing. The vectors are going this way. They can show the face is lifting and picking up, and the 3D camera does this. But this is what I've done with many, many patients over the past year to demonstrate what are we seeing or not seeing with these type of procedures. Now here's a before and after. Here's the before, here's the after. What I want you to look at is just overall, take a look at the facial region. If you look at this picture on the after, just look at the slightly lifted cheeks over here. The smile lines are naturally just filled a little bit. The edge is taken off them. I'll remove the markings and just glance real quick at each picture. This side just shows an overall rejuvenated look. I don't want you focusing per se on the pigmentation or the under eye pigmentation. That's something we didn't address, but the overall facial shape is more rejuvenated. And that's why this is a tool in the practice for rejuvenation and facial rejuvenation and overall youthful look. And you'll notice as I show you some pictures, I typically address the full face with these type of procedures. I don't necessarily spot treat. Before we get into all the science of how we make it and injecting some of it, I just wanted to show you a couple of before and afters. People love their before and afters. To me, before and afters are very individual. Just because one person gets a result with whatever you're doing doesn't mean the same result is going to occur in another person, but it gives people an idea for $3,000, $4,000, $5,000, $6,000, roughly what other people get. In this patient here, of course, we have the after picture over here. I injected the under eye, the lateral orbital rim, nasolabial folds. The lip area was really bothering her, so I did at the vermilion in the upper lip. Patient didn't want lip filler. I did the melomental fold or the oral commissure and the chin area. She did not have her cheek injected, but I did take some liquid Parap and injected the brow for plasma brow. And there, I'll remove these markings. Just to give you a rough idea, let's do one more picture here. So here's another before and an after. And if we look, again, I do full face with these 2 sessions, 6 weeks apart. Try and get them at 6 weeks, but if it's 8 or 12 weeks, that's fine, of course, not before 6 weeks. These cases I'm showing you all are at 6 weeks after the first one, and then this is 3 months after the last injections. So what we see, just kind of cleaning up the lower facial region here, injected the tear trough. I do the lateral tear trough with these 2, or the lateral orbital rim, and all of them get mid-face, all the ones I'm going to show you. And then I do inject nasolabial folds because the nasolabial folds look pretty amazing. They look natural. They don't have that filler effect, so I do it. But the overall skin texture, quality, and a bit of volume really adds the look. And if you just look on this side here, and then on this side here, just do the quick check, which one looks a little more youthful. And again, a lot of people don't want a facelift. They don't want fillers. They want all natural. Let's look at one more here. So here is another one, same thing, injected the under eye, the mid face. Again, I do the nasolabial folds and a lot of lower face with these. I guess what the areas I don't do with this product, I don't do temples. I don't think it's robust enough. You could do preauricular areas. I tend to grab PLLA or Sculptor to do preauricular areas. One could, but I haven't done a lot of preauricular. I stick more with the window of the face because I'm trying to, the window meaning, let me remove these markings, what people see when they go home, and that's this whole area as opposed to what is the frame of the face around the edge, or I'll remove those to show you what I mean. When we inject the frame, which is also important, a lot of people don't see that, so they think it's a waste of money. So when I'm playing with these products and trying to get the best results I can, I'm injecting what I call the window. And you can just see an overall, I want to use the word lifting effect. It does look like that, a bit of lifting, a bit of volume, but overall rejuvenation is what I want to get across to you. So if we look here, what are the benefits of using blood products? It's well accepted by discerning clients. So people are okay to get all natural procedure. That's about 90% of the all-comer market. Only a very small percentage of people want toxins and fillers. So we can capture, therefore, the all-natural market. It's easy to add on to existing menu services. So I don't like to look at anything as a standalone, just come get this one procedure. You don't need resurfacing, you don't need fractionated RF. I use this as a tool for everything else. So you can add this on. There's no interactions with a lot of products like or people who have, say, autoimmune problems. They might not want biostimulators or anything synthetic. So you can add this on readily with your existing devices or menu services. So it's often safe for people with health issues. There's minimal consumable, which is getting more and more important as we see inflation. The product cost is rising. So a lot of people like the fact that there's not a lot of consumable. You're being paid for your skill set and what you can do, your injecting technique, and making the best PRF gel or easy gel that can be made for a client. So I think this slide is worth looking at. Over here, we have PRP. You'll notice a lot of clear liquid, a lot of water, probably albumin, but here's the plug. So you see I'm gonna outline the plastic or whatever they make the plug of nowadays. There's various materials, and the question is, with this plug, does some of it actually get into what we're using? That's a question, but irregardless, we have that plug. It's a fast spin speed. Here's the buffy coat, and you can just see this is the only layer that really is going to have anything worthwhile in it in terms of mesenchymal stem cells, growth factors, and what we're looking for. That's the buffy coat. If we come over here, this is what platelet-rich fiber is going to look like. So you have to extract the buffy coat, but look at the difference in color. You can look at this tube. You have a lot of cells, white blood cells. Of course, our platelets are scattered through here because they're lower weight, so they're near the top. And you don't get the yield that you do over here with the platelet-rich plasma. But a lot of this yield obviously isn't goodness and factors like we want. It's a lot of water, plasma, and proteins. If we move through here, let's look at the next slide. The albumin that we take, that we heat up, this is what it is over here. And one of the things to consider is that serum albumins are the most abundant protein in there, making up 60% of them. But here's the important part. What are we heating it to? 70 to 75 is what I heat mine to, but the hydrodynamic radius of the human serum albumin increases, look at this, 4 times at around 75 degrees. We heat for about 10 minutes. 4 times its size. So that means that's the volume the patients are going to see in that initial fill. Remember, that volume lasts likely somewhere around 3 to 4 months, but that's from the human serum albumin unfolding in that volume effect. But it's the goodness and those regenerative factors that are suspended in there that actually I'm more concerned with. I'm more of thinking of long-term regeneration, long-term rejuvenation, and long-term youthful looking skin, face, and result. But I know people like instant, but that's why we heat the albumin component. If we look at this slide here, just talking about the spinners, your spinners should be tested with the tube that you're using. They work together. This is what I was talking about with the G-force. We want to measure the G-force at the buffy coat of the tube. Some tubes are 10 ml, some 13. The ones I use are 13 ml. You want to measure the G-force there. As you move out further, as you increase the speed, all those factors are going to change the G-force. Where we're concerned about is that buffy coat. So some people like horizontal centrifuges, some people use fixed. I use fixed right now. I have 8 spinners. I like them all, I test them all, but the fixed spinner with the 13 ml tube is studied and proven to have the factors we need in them. We do want white cells in them, and we have shown that in these tubes there are white cells that we're looking for. I wanted to show this slide because a lot of people want to use these type of products as fillers and equate them, and I hate equating things. It's like equating a laser to radio frequency. They're two different things. But what are we doing here? And we take a lot of this science, in my opinion, from fat transfer. If we look here, when we transfer fat, there's 3 main theories, but one thing we know is each fat cell likely needs blood supply if it's going to survive. A lot of the fat cells die. That's part of the theory. They die off, and it's the mesenchymal stem cells, the adipose-derived stem cells listed here, that remain, and over the ensuing weeks and months, you get regeneration of the fat. So you get neoangiogenesis and rejuvenation of the fat, and the mesenchymal stem cells lead to more fat cells, new fat cells. It's not that all the fat that's transferred survives, because each fat droplet, each fat cell needs its own capillary blood supply, and that doesn't happen. And that's why you see final results months after, we often say 6 months after fat transfer. So it's the stem cells that are very important and the growth factors that lead to the regeneration. And it's my belief that is what we're seeing with platelet-rich fibrin and platelet-rich fibrin gel, that regenerative fraction that is giving the rejuvenated skin, why we see some volume, why we see better skin texture, and you see from the before and afters the results that you can get. But I think studying fat transfer gives you a window into what we're doing. And then there's over 150 growth factors, as you see here. The ones that we're interested in: vascular endothelial growth factor, transforming growth factor beta, and platelet-derived growth factor, fibroblast growth factor. Everyone wants fibroblasts for elastin collagen production. So studying that science is important to know what we're doing. Now, I mentioned fat transfer and mesenchymal stem cells. Fat has the most mesenchymal stem cells. You have bone, and then you have blood. The blood is the low-hanging fruit. People don't mind you taking their blood, but they don't want you going in taking their bone marrow, and a lot of times they don't want you taking fat. If you're doing a procedure like we're doing in clinic and we're not already taking fat for another reason, it can leave divots. It's a whole other procedure, time-consuming, so on and so forth. But to demonstrate that there are stem cells in the blood, and they're measured by different markers so that we know they're in there. And when we measure stem cells, the other thing we know as we increase, look at down here, 2700 RPM, as we increase the spin speeds, we get less mesenchymal stem cells in our buffy coats. So stem cells are important, and measuring them are important, and that's why I believe a slow spin speed is important for good results. And this just showing, because we would have to then show, do we have mesenchymal stem cells in PRF? 0.4 to 2% of total cells in PRF have been shown to be mesenchymal stem cells. So they're there, and again, you got to measure, you want to measure, know you're using the right spinner and the right tubes, but they're there, and it's very important to have them to get results. Okay, so let's look at a video of what we're doing, how we make it. So I have 2 vials of whole blood here. I often get 4 because I do a lot in the face, but I'm demonstrating it here. Most clinics will get 2. That's going to yield you 5 mLs. Let's watch. I have the blood here. I have a cooler and I have a spinner and my heater. So I take 1 whole blood, put it in the cooler, 1 whole blood, put it in the spinner with a tube to balance it. Very important to have a balanced spinner. I spin it fast, and I'm getting my albumin there, around 2200 RPM for 7 minutes. Then I take the one that was in the cooler and I spin it slow. That's going to get me my platelet-rich fibrin. I'm going to spin that at around 1100 for 5 minutes. A little faster because it was blood that was cooled. Now I take my albumin and I'm extracting that into my white syringe. So I can take this, I can take some red cells out of here because it's going, I'm not adding a lot of other red cells. I'm going to get a total yield of 5 mLs, so you can get more red cells than just in pure PRF. I heat it. So I'm heating my albumin. I get about 3 cc's of that albumin. You can often get 3.5. And then of course my PRF is still spinning. My albumin, I heat typically 72, 73 degrees for 10 minutes. Here's my PRF that we all know. So I have my PRF, I put it on my rack, and I'm going to extract my platelet-rich fibrin while I'm heating my gel component. So I take the top off of these vials. You could put the syringe through the top if you want. I use a 19 or 20 gauge syringe. Now you manually get the buffy coat, and this is the great part. There's no gel tube separator like there is in platelet-rich plasma. So I can take red cells, some red cells at the bottom of the buffy coat where I know the white cells will be. And I'll get about 1.5 mLs in total. That's what you can get from a 13 ml tube. I'm using the Easy Gel system and the Easy PRF tubes and spinner. So I put the top on that. I put the PRF in the cooler so it doesn't clot. Then after 10 minutes, I have my platelet-rich fibrin gel, and you can see that here. I take the gel, I put it in the cooler for 2 minutes because we don't want to mix hot gel with cool PRF. We want cool gel and cool PRF because the PRF we want to keep alive. We don't want to heat it to 72 with the gel. And this is just showing you roughly the consistency that I like to have for my gel product. This is just the albumin component, and again, the syringes are heat resistant, and of course I did heat that up. So that gives you an idea. And then I take my PRF, there's a connector tube here, and I'm going to connect them, and I'm going to mix the PRF with my gel component. And I'm going to mix them back and forth about 20 times. That's what I've been doing. I know from the old days, 2007 with the Radius, it didn't come with lidocaine, and about 20 showed that we got a good mix. Now I'm taking my mixed product, I'm putting it into my 1 ml syringes, and these are coded red, they're color coded red. And I'll get 4.5 mLs, 3 mLs of the gel, 1.5 of the PRF of these. So 5 red 1 ml easy push syringes come with the kits. So I'm filling those up, and then I will go ahead and let's go to some injections. You can see a close-up of it here. So let's watch some injections here. In my complete training video, I go through where we think the ligaments are, zygomatocutaneous, tear trough ligaments, etc. The malar pad is something a lot of people are trying to address, that fibrous tissue laterally. And then of course the prezygomatic space in the midface, which we often fill. I go through that in the video. But for this purpose, I want to show you I'm going to have a 1 ml syringe. I do a lot of tear troughs. People call it tear troughs with this. And you have various entry points. In this case, I'm coming laterally. She has pretty good mid-face volume, but I want to get the under eye. And you see the pigment around the under eye area. That's a lot of sun damage. That's what leads to a lot of fine lines and aging of the eye. But what I'm doing here, this happens to be a 25 gauge, 1.5 inch cannula. I often use actually a 22 gauge. And this doesn't draw water in like a hyaluronic acid filler. But so I do what I call a two-step. I go the first layer on the bone. Often I'll come back and put it more superficial. The vibration gold device for some pain control. I don't use a lot of anesthetic at all. There's no lidocaine in this product, no heparin or sodium citrate. You can see my cannula moving medially, and I'm just what I believe is under the orbicularis oculi muscle. So I'm a little deeper here. If I did come superficial through it, I'm not too concerned. It's not filler, doesn't draw water in. And remember, what I'm doing is depositing the gel matrix, of course, for immediate volume. Our patients love volume, but me personally, as a physician, I'm more concerned about the growth factors, stem cells, and rejuvenating factors for the under eye for long term. I'm looking at months and months and months. People do this once or twice a year, and maybe if they take care of their skin, they don't have to do it every year. So it'll depend on her aging rate, hormones, and how much she avoids sun, how good skincare she uses. Here I'm doing the lateral orbital rim. I think this is often missed, especially with fillers. People don't fill this. Of course, going through the ligamentous structures here, the tear trough ligament medially, the orbital retaining ligament laterally. You can see sometimes you got to pop through it, but I'm at a little bit of a deeper level. I get through it, and then I inject it. But I think it's important to address, otherwise there is a hollow laterally that is and can be an aging feature. There's very little discomfort with this product. It doesn't burn going in, and you can mold it afterwards, as you see I'm doing here, which is really nice. So you can even take a Q-tip and mold it up, down, and around. So I saw this area, and then I go back in again because I looked, I said, well, actually now we can fill the midface. It won't look unusual. The tear trough, as it's known to many people, or the lid cheek junction, looks nice and smooth. Let's give her a little anterior projection. And when we're filling, we're always looking, of course, we're looking for any blanching, any signs of problems, but we're also looking at the aesthetic result. If we get a good result, we can move on and maybe even do the lateral cheek. Maybe we can do the medial tear trough, but we're looking to see how good of a fill we get. So I wanted to give her a little more anterior projection, and that's what we did. We can do it through the same opening, or I could have come inferiorly and injected that way too. That's another great way to do it. So this patient was also concerned about her lower face. And of course, the lower face often ages quicker than the upper face, especially as hormones change. Pick your injection opening, your cannula opening. In this case, I'm coming in laterally. Vertical lip lines were a big issue for her. She had filler a long time ago, and it made her look ducky, so we thought we would use this product. So I want to address, of course, we would address movement with toxins. We can do that at the same time. But coming in laterally, I do a lot of vermilion border treatments with this, because I do still have a lot of patients that if they might have filler or they don't want the filler look. And this works excellent. And you can see I'm just coming up, I'm injecting antegrade. So I'm injecting a little bit to create an opening, and then I'm moving my cannula through. And here I'm moving it up to the GK point. I'm going to inject it, and I can tell her she's not going to have a ducky look, maybe for a day or two. You can twist it and then do the nasolabial folds, or you can then come and do the lower lip. Just for time's sake here, I do a lot of chins, especially for females. They lose bone, lose fat, and the skin texture changes. They don't like it, and this is a very natural way to get rejuvenation. And I'll inject about 1 ml per side. I'm fairly aggressive in the anterior jaw and the lower face, Again, the microcannula technique. There's very little bruising with this procedure. There's not a high G prime like a calcium hydroxylapatite filler, which can go through vessels, shear them, and create bruising. It works very well with the body, so we'll find, much like Sculptor doesn't have a high G prime, not a lot of bruising, especially using the cannula technique. Very little discomfort. And that can kind of demonstrating to you some of the injections. Here, I often finish up, I say, hey, do you like your brows? A lot of people have their brows that fade over time. People want more hair. Hair is in for the brow. So I'm doing some PRF liquid I had left over. Again, I usually get 4 tubes in total. And I'm going to inject it at the brow for hair growth, for a little bit of projection. The brow frames the eye. A lot of people like a little lifting of the brow, and rejuvenating the fat pad of the brow is very nice. And people like that. Hey, doesn't take long. I just add a little bit of PRF above the brow and gives a nice projection, can help with hair growth. You can see looks like she may have had microblading in the past, so brows were important to her. So that gives you an idea of some injections, but I tend to do 5 to 10 mLs total full face treatment for just about everyone, spaced by 6 weeks. So in conclusion, PRF gel, it's the latest generation of an all natural injectable. Many people are waiting for all natural injectable products. It has many advantages over the liquid, and it can be combined, as I showed you in that video, with the liquid. It's easy to produce, and it may release the growth factors longer. I say may because it certainly seems that way, and you get the instant filling effect. There's no real study or data that I can hand to you right now that's got great data to show you that, but there's a lot of anecdotal evidence, and also in dentistry and orthopedics. It's very versatile, as you've seen. And the concept of less spin speed for more cells, and then that longer scaffolding holding all that goodness in the face, is why we're getting such good duration out of this. And you can combine it with what you're using. Sure, you can have the all natural clinic where you just do this procedure in PRF. I think it would be busy, it would be fantastic, but you can combine it with your fillers, toxin devices, and your biostimulators. I thank you for your attention to this. Love to hear your feedback. Certainly get a hold of me, Instagram, YouTube, or social media. Happy to answer your questions, as well as at aesthetictrainingcenter.com. Have a super one, and thanks for joining me here today.
Thank you, Anil. It's phenomenal. I would say it is definitely what you should know about PRF gel. And I hope you enjoyed the special edition of Pre-Congress Advanced Injectable Workshop 2022. Thank you for joining us tonight, and hope to see you again in the Congress tomorrow. See you. Have a good night. Bye-bye.